This is the first lady who was actually conceived through IVF in Newcastle, and she's had a couple of kids since then. And interestingly, when she was conceived in Newcastle through IVF, the statistics in terms of success rates was that per IVF cycle, the success rate was a whole lot less than 10%. And across that time, since '84, it's definitely grown significantly to have success rates above 50% per transfer. I'm not sure if she still lives in Newcastle. I was told that she does. So what we'll do is just go through like a little bit of theory stuff, but importantly, the definition of infertility. If you look at a textbook, the definition of infertility says that couples try to conceive for 12 months without a positive pregnancy test. This slide breaks it up into two sections, and it's more just to give a little bit of a hint as to when people should start seeking investigational treatment for fertility. But we try and suggest that women that are greater than 35, if 6 months has gone by without falling pregnant, that's probably the time to seek an appointment and information and treatment. Or couples where the lady is less than 35, 12 months of trying to fall pregnant. Like, that's not a hard and fast black and white rule, but that just still gives a little bit of a guide as to what we kind of consider to be normal and what we think is the time that couples should have a think about investigation. And the reason that we get that figure is that this graph looks at the percentage of couples that have fallen pregnant per month. So you can see on the first month, which isn't written there, but on number one, around about 30%, I usually quote about 25% of couples will fall pregnant in the first month of trying. And after 2 months, that's risen to around about 50%. After 6 months, it's at around 70%. And at 12 months, it's around about 90%. So that's where we get our definition from. Around about 10% of couples will have not fallen pregnant after 12 months of trying. Now, obviously, this graph is for women in the younger age group, and as you'll see in a minute, this graph isn't applicable for someone who's 40 years old. The chance of someone falling pregnant that's 40 years old in the first month of trying is somewhere around 5 to 10% rather than 25 to 30%. And as I just said, age in years for the female has an impact on the percentage chance of falling pregnant. So a lady that's 22-year-old, that's where we got our 25% chance in the first month, and someone who's 40-year-old, it's considerably less than that. So what we'll go through now are just the causes of subfertility, and then the type of investigations that we use when couples seek an appointment, and then we'll just go through the types of treatment that are often dependent on what the cause of the subfertility is. So the causes of subfertility we break up into male factor, female factor, and unfortunately for couples that come, there are times that we perform every recognised investigation that we have, and we still don't have an answer for why they're unable to fall pregnant. The type of investigations that we initially look at, so for males we ask for a sperm analysis, and we look at three things in a sperm analysis. We look at the number of sperm, so we like more than 15 million per mil. We look at the number of sperm that are actually swimming forwards, and we like around about 40 to 50% to actually be swimming forwards quickly. And we also look at the number of sperm that appear normal. And when we're giving sperm analysis results to blokes, they kind of get their chest propped out a little bit. With the first couple, they think, yes, I've got 25 million per mil, and I've got 70% of the swimmers that are actually swimming. But then when we tell them that only 4% appear normal, which is normal, then they all look a little bit deflated. So we leave that result until last, but we expect 4% of sperm to appear normal under the microscope. So female factor subfertility is a little bit more detailed, and that is that there are a considerably high number of causes of female factor infertility rather than the simple, sperm analysis for the male. Female factor infertility, this is not like a complete list. there are textbooks on female factor infertility, and I've tried to condense a whole textbook into one slide or a couple of slides, but this just gives a bit of a general overview. So tubal damage, so blocked fallopian tubes. Obviously, when the ovary gives up an egg, the egg needs to travel down and meet sperm. And having blocked tubes is definitely one cause of subfertility. There are times that we don't ever have a reason for why tubes are blocked, but we do know that risk factors for tubal blockage are women that have endometriosis, which we'll talk about in just a moment, women that have had multiple operations on their tummy, so adhesions within the pelvis can cause blocked tubes. And there are also times where infection, so STDs or even pelvic infection without an STD, can cause tubal blockage. The only real way that we can test tubes effectively is to squirt dye into the uterus and watch dye come out the end of the tubes. And we either do that at the time of laparoscopy, which is keyhole surgery to look in the tummy, or we can do that awake by, very similar to a pap smear, but putting a little tube through the cervix and squirting dye into the uterus, and under ultrasound guidance watching the dye come out the end of the tubes. The downside to blocked tubes is that patients always, when I say, you know, the test that we've done suggests that the tubes are blocked, patients always have the impression that we can then unblock tubes by some surgical procedure, and the downside is that the success rates of trying to unblock tubes is extraordinarily low, and we can consider that the majority of couples where tubal damage is the cause, the majority of couples then require IVF as the treatment. But if there is an upside to that, if we're simply overcoming a physical blockage of the tubes, we're presuming that egg quality is good, and we're presuming that the sperm analysis is good. So when we end up putting sperm and egg together, the success rates for those couples tend to be quite high. Any questions so far? No. You've got to hit me with a couple of questions. So endometriosis is a really difficult condition to diagnose and also treat. So endometriosis is where cells that usually line the inside of the uterus grow on the outside of the uterus somewhere. And the difficulty is that women can be very symptomatic from endometriosis and have only a little spot of endo, and there are some women that can have extensive endometriosis in their pelvis and have no symptoms at all from it. Most of the literature that we have suggests that moderate to severe endometriosis is definitely a cause of infertility. A lot of the time we probably consider that it then causes tubal damage. So endometriosis causes inflammation and scar tissue, and in a certain percentage of women, the tubal damage that is as a result of the endometriosis is the cause of the subfertility. Most of our studies that we have looking at endo say for couples that have been trying for 12 months, if it is that we do a laparoscopy and we burn endometriosis, then those couples have a significantly higher chance of falling pregnant in the following 3 months after that. Which is not a huge increase, but certainly for a small percentage of couples, that is one of the more conservative approaches that sees them fall pregnant. Going back to the tubal damage, and I'll talk about treatment later, when women have that test, it effectively, as long as dye comes out at the end of the tubes, it effectively flushes the tubes. And we do know that that's a treatment as well as an investigation. So flushing the tubes has a significantly higher chance of falling pregnant again in the following 3 months after doing that. And we're not really sure of the mechanism. It doesn't completely unblock tubes, but obviously if there is some small blockage within the tubes, it helps overcome that.
Matt, after that procedure,
Yep.
Is there then a higher chance of tubal pregnancy?
Not that I know of. I would suggest that if tubal blockage is the cause of the subfertility in the first place, then a partial tubal blockage would have an increased risk of an ectopic pregnancy. But I don't think that there is an increased risk if we unblock the tubes and then it sees women fall pregnant. I think that risk, if women had an ectopic pregnancy after that, was due to the underlying reason that the tube was blocked in the first place. Does that answer?
Oh, yes, and no, I didn't mean that the actual procedure made it high risk, but that if there was any vestige of blockage still there, an egg was still able to come through the tube and be fertilised, that it would then not be able to get any further.
Yeah, absolutely. Yeah. So if tubal blockage is considered to be the cause of the subfertility, then those women definitely have an increased risk of ectopic pregnancy when they fall pregnant. And I can't give you the exact numbers, but I do know that if someone has had one ectopic pregnancy in the past and the background chance is around 1%, then the chance in a second pregnancy is probably about 10%. And that doesn't matter how it was treated. So.
Question. Does it apply to just people that have never had children at all? Or could it apply to people that have had maybe a child in the past?
Do you mean could tubal blockage apply to?
No, just subfertility.
No, so there's such thing, although it wasn't on the first slide, there is primary infertility, which is never having fallen pregnant before and trying to conceive for 12 months. But there's still a reasonable number of women who have had a baby before and then try again and unable to fall pregnant, and that's called secondary infertility.
In our initial testing, when we first went to see our doctor, they were mainly just blood tests, ultrasound, and for me, obviously, sperm count. The initial tests look good. We've still got to go back for further testing, but would we find out through initial testing if we would be coming up against any of these factors, or do we have to specifically test for them?
Yeah, so tubal blockage is something that we need to specifically test for, and obviously there's different practice dependent on which doctor people see, and I'm not saying one is good or bad, but usually testing tubes, at least in my practice, is not one of the baseline initial investigations, unless couples come and they say, we've been unable to fall pregnant, and by the way, I had a severe pelvic infection after the birth of my first child, then that would tend to suggest that the chance of tubal blockage is high, and I would suggest that as one of the initial investigations. But in my practice, you're right, I tend to try and, when people make an appointment, I tend to try and send them out bloods and a request for a sperm analysis before they actually see me, so that just gets rid of one complete consultation, and then go from there. And the bloods test for things like ovulation, which is one of the next causes of infertility. So obviously women need to ovulate in order for the ovary to give the egg up to fall pregnant. And the most common cause of anovulation is polycystic ovarian syndrome, which in itself, textbooks upon textbooks written about it. Polycystic ovarian syndrome is a condition of insulin resistance, but also those women tend not to ovulate regularly. The definition of it is that you have to have 2 out of 3 things. One of them is not ovulating. Another is polycystic ovaries on ultrasound. So it is a misconception at times that women have an ultrasound and it's reported down the bottom as all little cysts around the outside consistent with polycystic ovaries, but they don't necessarily then have the condition where they don't ovulate. And the third thing with polycystic ovarian syndrome is a high androgen hormone in the blood, so high testosterone, and we test for that as one of the baseline hormonal investigations that we usually test for. Polycystic ovarian syndrome is really common, and it tends to be one of the conditions that we can most easily treat rather than needing to proceed down the IVF path. And the way that we treat it is ovulation induction with medication that most people will know as Clomid, but we have now changed to something called letrozole. And I'm fairly upbeat when couples come and we figure out that they're not ovulating, because it tends to be one of the simpler fixes. I haven't articulated that very well, but premature ovarian failure is obviously a horrible condition, and around about 1% of women go through menopause before age 40. The way that we test it is with a hormonal profile that we perform. Premature ovarian failure, the absolute downside is that if the ovaries have stopped producing estrogen and have stopped producing eggs, and women are prematurely menopausal, then there is no fix for that. it doesn't matter how much medication we give them to try and kickstart the ovaries to producing eggs. The fact is, if the ovaries have stopped working for whatever reason, and a lot of the time we can never find a reason, that those women then require donor egg. And I've got a couple of patients, one patient that's 19 years old that's gone through menopause at age 17, and another patient who's actually had a baby who went through menopause at probably age 20 and had donor egg and has got a 1-year-old baby. So it's a horrible time, but still occasionally we can have a really good outcome for it.
In that case, for those two, did they have to choose the donor egg, or you?
Yeah, no. So we'll go through donor egg shortly, but basically women who require donor egg, and at this clinic there are numerous reasons why women come for donor egg. Premature menopause is one of those, and the other common cause is women coming to seek fertility treatment that are well into their 40s and who try and have an IVF cycle, but the response of the ovaries just doesn't happen, and who elect then to go and seek an egg donor. The clinic here doesn't actually, we do have a donor egg register, but I'm not sure how many women are actually on that register currently. We'll talk about donor stuff soon. We have a donor sperm bank here, and that's much better than it. Oh no, it's not full. We still. No. So the problem was that years ago you could pay, blokes could be anonymous donors, and they would actually get some money for donating sperm, and now that it's illegal in Australia to have an anonymous donor, and we can't pay people for donor egg or donor sperm. The law says they are not to be paid for that. Yeah. So interestingly, after all of our investigations, we're still left sitting in our consult room saying, you've not been able to fall pregnant now for 18 months, and we've done every investigation and we can't figure out the reason. And at that point, couples are left with either continuing to try naturally or going down the path of IVF, that we'll go through the process soon. So someone did had a little bit of a think, and they came up with the conclusion that the average time to fall pregnant, if there's no problem, is around about 3 months. Yeah. If there's one factor, and obviously it depends what factor it is, but something like moderate to severe endometriosis, that the average time is 2 years, with 2 factors such as moderate endometriosis and a sperm abnormality, that the average time might be 7 years. And I still wonder who did the study and waited for 40 years to see if they would fall pregnant, and I would suggest that those women are probably then menopausal. So I think that's probably a software generated number more so than reality. So for good reason, couples always say, we've been unable to fall pregnant, we haven't found a cause, what can we do that increases our chance of falling pregnant naturally? And the downside is that there's no one answer to that. We do know from our research that couples are at either end of the spectrum. That is, if you say that this couple smokes, drinks heavily, has a high BMI and doesn't exercise, that their chance of falling pregnant naturally is considerably lower than the complete opposite. If we were to pick out one of those things, it is weight and body mass index. And the reason that I say that is more specific to couples where anovulation due to polycystic ovarian syndrome is the cause of the subfertility. There was a reasonable study that was done looking at women that fell into that category, so unable to fall pregnant because of polycystic ovarian syndrome, that had a BMI, I can't quite remember whether it was a BMI over 30 or 35. And they did a study of an initial treatment of just weight loss. And the average weight loss in the study was somewhere between 5 and 10%. And by that, I'm trying to make the point that it wasn't halving their weight, but a 5 to 10% weight loss for women that were infertile due to PCOS with a high BMI, saw around about 70% of those women resume ovulation, which is fantastic. because it's a whole lot cheaper than proceeding down the path of IVF. And in actual fact, even the medication that we give to women due to polycystic ovarian syndrome to get them to ovulate still has a risk with it. So letrozole increases the chance significantly of having twins. And whilst couples say, you know, we've been trying for this long, if we get 2 babies, that's fantastic. It's actually not a great obstetric, you know, situation to be in, and outcomes for twin pregnancies are remarkably poorer than outcomes of having 1 baby inside. Which, on a side note, is why we only ever put 1 embryo back in the uterus and not 2.
What is a healthy BMI for a...
So 20 to 25 is considered normal, and then 25 to 30 is overweight, and then 30 to 35 is considered obese, and then over 35 is morbid obesity. So the question is, when is the right time in a cycle to fall pregnant? And you're actually not silly if you don't know. There was a survey done of couples that were unable to fall pregnant after a year, and the question simply was, when's the right time in the cycle to have sex to fall pregnant? And a reasonable percentage, that is over 50%, did not know. And if you look at 0 as ovulation day, and if you look at -1 as having intercourse the day before that, and -2 intercourse 2 days before actual ovulation, it's having intercourse 24 hours prior to ovulation that sees the highest chance of falling pregnant. The thing that's not on this slide is that we should probably continue this graph to show having intercourse the day after ovulation, and it's 0. So there's never been a documented pregnancy of a couple that have had intercourse after ovulation. And that poses a little bit of a problem, because patients historically have tried doing their basal body temperature to see if ovulation has occurred, and it tells them that they should have been having intercourse, you know, 3 or 4 days ago. So it's a retrospective thing. What we have here at Janaea is ovulation tracking, which is blood test rather than urine test, and it prospectively allows us to tell women that you're going to ovulate in 36 hours, and so now's the right time to have intercourse. And so, especially for couples that have been trying for over a year, having sex every day is not a practical thing, and this doesn't happen. And pinpointing the right time is something that we find, at least I find in my practice, very helpful for couples, especially when they're wanting to try absolutely everything before proceeding to IVF. This is definitely a step that probably 80% of my fertility patients want to undertake. Does that graph make sense? I mentioned basal body temperature. This is the graph that some of you may well be familiar with. And after ovulation, so progesterone is produced from the ovary after ovulation. And the progesterone is the cause of the high basal body temperature. And you can see in this graph, after ovulation, the temperature goes up, and that tells women that they ovulated some time ago, and it isn't really helpful prospectively to help with the timing of intercourse.
Is there something we can do at home to be able to...
So patients historically have used the Wee on the Stick kit, and I get the question all of the time, are they accurate? And I suppose that there is some benefit to them, but I don't think that they're as accurate as us doing blood tests and looking for a spike in luteinizing hormone, and it's the spike in luteinizing hormone that occurs about 36 hours prior to ovulation that is very specific and the key.
So then you got 12 hours to...
Yeah, mostly that's when the blokes get the phone call.
Yeah.
I think Jess spends the majority of her days telling people to go and have sex.
Really? Wow. That's, what a job.
Do you do regular blood tests or just one?
So Jess, if you want to speak on it, you can.
I'm Jess. Hi.
Hi, Jess.
With the ovulation tracking, we need a referral from your GP, and this is the form that you can get filled out. Bring it to us. You ring me with your period, and then we start tracking your cycle with blood tests. So it's depending on how long your cycles are. We would normally start tracking from day 10 to 12 of your cycle, And some girls need 5 blood tests before we can see that they're about to ovulate. Some need 1. Just depends. And then, like Dr. Holland said, I ring you and say this is the day. And then usually you don't need to do it every day. I would normally say either today and in this 2 days later. Just depends on where your hormones are at and if it's a weekend, because the service just runs over Monday to Friday. But then once that's done, we check the progesterone level a week later, just to confirm that you have ovulated. And then we'll do a pregnancy test the following week if your period hasn't arrived. So we've been doing this for about 2 years now, and it's been really successful. We've had, I think, over about 60 pregnancies, and they've all been, we've had just positive feedback throughout the whole cycle. The best thing about it, it's free, bulk bill for 3 months. So if at the end of that 3 months you aren't pregnant, then you can come back to see Dr. Holland or any of the other fertility specialists, and then we'll go from there after that. But please take one of these today. It's got my card on it with my name and number. Please call that mobile if you've got any questions, and there's a little information booklet as well. Is there any questions about that?
Yeah, so do people call you on the first day of the period?
Yeah, first or second. It's not a huge rush because we don't have to have any blood tests from until later on. Yeah.
So the question is always when to have an appointment, and there's not ever definitely a right answer to that, but there's a few things. If you know that you've got blocked tubes because someone has done the test 5 years ago, then there's no use waiting and trying to fall pregnant for a year before you go and have a chat to a fertility specialist. Obviously, if we went back to that first slide about definition of infertility, if you're over 35 and you've been trying for 6 months, I think that's a reasonable time to at least do some baseline investigations that we chatted about earlier. Or if you know that you have a condition. So one thing I will talk about in terms of the service at our clinic here is that we can create embryos and we can test them genetically for a number of different chromosomal problems, and then only put back genetically normal embryos, which is pretty cool. The most common reason that we do that is couples that have cystic fibrosis, so a carrier for CF, and around 1 in 25 Australians carry the gene for CF. So if a couple, both the male and the female, carry that gene, then there is a 1 in 4 chance of their baby being affected by cystic fibrosis, and that is one of the most common causes of testing embryos genetically before we then put them back in. But there's a range of conditions that we can test for. So obviously if there is a genetic problem that we are testing for, then that's important that we have a consult well and truly up front to talk about testing embryos. Recurrent miscarriage. So recurrent miscarriage is something that I see commonly in my rooms. It's a really sad time and frustrating time when couples can fall pregnant, but then the pregnancy continuing on being viable is the hassle. We do have a list of investigations that we perform for recurrent miscarriage, and part of the treatment is actually giving hope and giving information that we still think that at some stage a pregnancy will be viable and continue on. And even though we sit there and try and give that hope, there is a normal protective thing in couples' mind after they've been through miscarriage numerous times that makes them think that a 4th pregnancy would see them miscarry. But in actual fact, the odds, even if we can't find a cause, the odds are still in the favour with a 4th pregnancy to be viable. And we do have some treatment options. So that is that most of the research that we have suggests that even if we don't find a cause of miscarriage, that using progesterone treatment in a subsequent pregnancy slightly lowers the chance of having a 4th miscarriage. The numbers are not great, and it's not a miracle drug, but it is definitely something that's founded in research and something that we can look at patients in the eye and say, in actual fact, this treatment sees you have a lower chance of having a 4th miscarriage, which is good. We offer genetic testing, as I chatted to you about. We offer IVF, which we'll go through in a moment. Ovulation tracking has become a whole lot more popular in the last 2 years. That's probably because it's free. I've got AMH written down there, anti-Müllerian hormone. Has anyone heard of that? So anti-Müllerian hormone is one of the investigations that we commonly do as a baseline test that we send out, or at least my practice sends out before an appointment. Anti-Müllerian hormone, when it first came out, we thought it was going to tell us how many eggs were left, what quality the eggs were, and when women would go through menopause, and it's proven to be absolutely none of those. But it's still a bit of a screening test. We still do it for two reasons. One is that if we got an AMH level that was unexpectedly really low, then that tends to prompt couples to proceed to IVF treatment sooner than what they otherwise would. That's number one. And number two, AMH helps us determine drug dose in an IVF cycle. So there is something called ovarian hyperstimulation syndrome, which is in an IVF cycle us using medication to stimulate the ovaries to produce eggs, and we can overstimulate the ovaries, which can make women very unwell. And the chance of us doing that across the last few years, the incidence of that has decreased, and I think that it's probably because we're being guided a little bit in terms of drug dose by AMH. And so we're not seeing ovarian hyperstimulation quite as much as what we used to. Blokes that have a sperm analysis, it is common for it to come back with something that is wrong in the sperm analysis. And the most common thing is sperm number. Blokes always get a bit deflated, but it is important that we retest the sperm count 3 months later. This graph demonstrates the variation in sperm count, and some poor soul was subject to producing a sample for 120 weeks. I don't know how many times a week you produce. But this is one person's sample, and it just shows that there is a big variation in sperm count. And somewhere down the bottom, it all went downhill from there. He would have been in the depths of despair down here, thinking that the swimmers don't swim, and then back there he would have thought he was Superman. But it's just important to know, if we do a sperm analysis and we say there is something that's suboptimal, that is not the end of the story, that we always retest and we can see the sperm count come up, and we don't have a reason for that.
Is there a reason why he was producing more per mil 2 years?
No, because the answer then comes, is this something that he has done that has caused his sperm analysis to be high? Again, there is marketing around Menavit, and that company has shown that there is a decreased level of DNA damage in sperm on men with Menavit, but they've never demonstrated a change in pregnancy rates with it. So in actual fact, the thought about taking Menavit probably isn't there. There is still some truth to blokes that drink a lot and smoke a lot probably have poorer sperm quality and count than the opposite. And it's probably a reasonable life thing anyway, that improving all of those things is a good idea.
Can I just add something about the sperm test? If you can arrange a semen analysis to be done before, like Dr. Holland said before, he will organise that. But if you're doing ovulation tracking, if you can get one done before you start the tracking, that's really helpful for information gathering. We do them at the clinic, so if you're interested in that, just give me a call and I can help you arrange that.
Cool.
And on that point as well, without pushing our clinic, there are different criteria for producing a report for a sperm analysis, and there are some labs that we get the sperm analysis back and think, I'm not really sure if we can trust that analysis and get a second one. My preference is, especially for couples that are going down the IVF path, the embryologists here are the ones responsible for saying, in actual fact, we've looked at the sperm and we think that this sperm is suitable to put in the dish with an egg rather than needing to inject it. So in the end, the embryologist here will always want to look at a sperm sample in our lab, because they're taking responsibility for the way that they perform the IVF cycle in the first place. So assisted conception, Janaea, obviously reproductive surgery, so it is common for males to want a vasectomy reversal, and the two options there either to have an IVF cycle where we get sperm out of the testicle with a testicular biopsy, or to have a vasectomy reversal. And Robert Walcott, who was a fertility specialist at Janae in Newcastle, still does the majority of Australia's vasectomy reversals. I'm sure he still does lists at this hospital. He does a number of lists in some Sydney hospitals as well. I've put female surgery for fertility. The main surgery that we ever really perform is diathermy or burning endometriosis and checking tubes. Obviously, I've written fibroids there. Fibroids do impact on fertility, and at times we go removing fibroids, but it's not one of the most common operations that we perform with women who are having difficulty falling pregnant. So, assisted reproduction techniques, I spoke about ovulation induction, which is most common for women with polycystic ovarian syndrome. And most of the time we just do that through our rooms rather than the clinic here. So after an appointment or during an appointment, we write out a script for letrozole and we give instructions about how we induce ovulation with medication. IUI, I've written there, probably should be written in red because we do it often enough. The times that we use IUI or intrauterine insemination of sperm are single women or same-sex couples that have donor sperm that decide to have the sperm put back into the uterus at the right time in the month, rather than going down the track of using that sperm in a cycle of IVF. The donor sperm that we have at Janae here, the scientists have looked at, and some of the sperm, when it's thawed out, they say this sperm is only useful in a cycle of IVF to inject the sperm into the egg, whereas some, they will say this sperm looks like it would be useful to put into the uterus at the right time of the month. You will probably have read IUI on Google, that is treatment options for subfertility. We used to consider IUI as an increase in chance of falling pregnant. In actual fact, it's still a costly exercise to go down the path of IUI if we have unexplained infertility, and a bang for buck, it is not worthwhile proceeding. It's only really worthwhile for women that are using donor sperm. IVF and ICSI are the two procedures that we most commonly do at Janae Newcastle. So IVF is where we get sperm and put it in the same dish as the egg, and then we check for fertilisation the next day and let sperm find its own way to the egg. ICSI is used for male factor infertility, that is when there is a sperm problem, and that is when the embryologist grabs a sperm, and I've got a video of it, grabs a sperm and injects it into an egg and then checks for fertilisation the next day, which is pretty cool. And other fertility options or other fertility treatments that we use at this clinic are definitely donor egg and sperm, and we usually have an adequate number of donor sperm on file, but donor egg is a whole lot harder to come by. Did we say that there were any donors on the register at the moment? Or? None.
Is it because it's not encouraged? Or?
No, I think it's just, so to donate your eggs is more of an invasive procedure. That is, you have to go through an IVF cycle and have an IVF pickup, which we'll talk about. All of that comes with considerable time and a small risk associated with it, whereas donating sperm, slightly easier.
If you don't have donor eggs on hand, do you then go looking for them in other parts of the country? Or?
Yeah, absolutely. So a lot of women that come to us and say, I realise that I need donor egg and I'm bringing this person along with me that's willing to donate their eggs and I'm not paying them.
Oh, okay.
Oh, wow.
That is, yeah, you're still not able to pay anyone to donate their eggs. I mentioned IUI. So down the bottom, pregnancy rates of using IUI. That is, this is presumed couples that have infertility, and there is a slight increase in chance of falling pregnant with IUI, that is putting washed sperm into the uterus, but it's still expensive. So if you compare a 35% chance of falling pregnant by doing that 6 times at a very high cost, you actually have a lower chance of falling pregnant by doing that than if you have one cycle of IVF. Yeah. The IVF process starts, number one, with stimulating the ovaries. So a lot of the time, this sounds strange, but a lot of the time what we do is put women on the pill. The reason that we put women on the pill is that we time all of our IVF injections around a period, and when you stop the pill, you're going to get a period. So number one is we take control of the uterus by putting women on the pill. The next step then is stopping the brain from trying to tell the ovary to ovulate and produce eggs. So the way that we do that is via a nasal spray called Cineril. And once we're certain that we've shut the brain down as well, so we're shutting down a part of the brain that's pumping out FSH and LH, and we stop it doing that. Once we've done that, then we get women to have a period, and then on day 2 of the period start FSH injections. FSH is follicle stimulating hormone, and the idea of the follicle stimulating hormone is that it causes the ovary to start to produce follicles, and follicles contain eggs. And the way that we look at the response to the FSH is that we do ultrasound. So this is an ultrasound of an ovary that's being stimulated prior to an IVF cycle. And those black circles are follicles which have fluid in them. And at that point, the egg is kind of stuck to the side of the wall of the follicle, which is why we give, at some stage when the ovaries are ready, we give a trigger injection to cause the ovaries to ovulate. But obviously, we don't want the ovaries to go giving up all of the eggs. We actually want to get in and do an egg collection well and truly prior to ovulation. And the purpose of the trigger injection is to get the eggs to come off the wall of that follicle and just float freely around in the fluid, so that when we're draining the fluid, that it quite easily gets picked up. There are 2 types of IVF cycles that if you're kind of down the path of thinking about IVF, I guarantee that you will have come across. One type is called a long down regulation cycle, which is what I just described: pill, nasal spray, period, follicle stimulating hormone. There is another form called a short cycle, which is much more life friendly, but the results, at least in our lab, are that the long down regulation cycle has higher pregnancy rates. And although we're putting couples through a more labour intensive process, we're still going to stick to the procedure or the pathway that sees us have the highest success rates that we can. That doesn't say we never use a short cycle, but the majority, I think around about 90% of our IVF cycles are long down regulation cycles. So egg pickup, I'll talk about this more in the minor procedure room, but basically with an egg pickup, once we get to that point of giving the trigger injection, then we're in the lab picking the eggs up 36 hours after that. The procedure is done under like a twilight anaesthetic, so we use midazolam and we use fentanyl. Fentanyl is a pain reliever, and midazolam just bombs women out and they can't remember anything. The important thing to know in all of this process is that there is a natural frustration between the scanning, where you're looking at 20 follicles, and then having egg collection, where each follicle does not have an egg in it. So it is really common for us to get 10 eggs when we're looking at 20 follicles, which disappoints people, but it's normal. And then there's more frustration the day after when 7 fertilise, and then there's even more frustration when at day 5, when we're putting the embryo back, the most common situation is to have 1 fresh embryo to transfer and none to freeze, even if we picked up 10 eggs. And despite the fact that we say that, there is still a hope, and of course there is a hope that we get more than 1 day 5 embryo, so that we can then freeze that one. But the realistic expectation is that most couples get 1 fresh embryo to put back in on day 5 and then none to freeze.
So you only implant 1, but you can freeze the others if
Yeah, absolutely. Yeah. So we would hope that we implant 1, women fall pregnant, and then for a subsequent pregnancy just need a frozen embryo transfer rather than needing to go through all of that egg pickup again. Again, it's common when we've picked the eggs up for women to want to know if they're good quality. And over on the left you can see the egg, which is the black area in the middle, and it's surrounded by fluffy cells, and the embryologist cannot determine whether that's a mature egg, simply by looking at it there. It's when it's in the lab later on, they can then say this is a mature egg. So the question is, should we be using IVF, which is where we're putting sperm in the same dish and allowing fertilisation to occur naturally, or should we be using ICSI, where we're injecting sperm into the egg? There are reasonable papers to suggest that performing ICSI, that is injecting the sperm into the egg when there is no male factor infertility, does not have a higher chance of having a baby down the track. The reason I bring that up is that there are some IVF companies that do ICSI just about as their stock standard treatment. We just tend to use it only if it's necessary. That is, we use ICSI mainly for male factor infertility. There are some exceptions to that, but it's not very common at all. This next slide is actually ICSI, so it's an embryologist picking a sperm up and then putting it into the egg, and it's pretty cool. That's if it works. So this is the day after egg pickup, and the bloke's produced a sample. Yeah. So the embryologist there breaks the tail of the sperm. Breaking the tail of the sperm for some reason helps fertilisation. I'm not exactly sure of the science behind that. So once it's incapacitated, you don't need to feel sorry for the spermie, it's okay. So they pick it up. And this is an egg that has been stripped down, so all of those fluffy cells on the outside have gone. And this is under a microscope. The embryologist will hold the egg to stop it from rolling with a little pipette. So that's holding the egg. So what you'll see the embryologist do is go through that membrane, but then the next thing that they'll do is they suck back a little bit of the material from within the egg just to make sure that they're in the right spot. And then next they'll inject the sperm into the centre, which is just there. Yep. Then they take that out and then they'll flick it off to the side and they'll do the next one. It's pretty cool, eh? And then the next day they check for fertilisation, which is you can see the two circles in the middle. Yeah. So then fast forward a little bit, the embryo then goes into an incubator, which these are newer incubators that Janaea developed and demonstrated a significantly higher blastocyst or day 5 embryo development rate than the previous incubators that we had. But over on the left is a video if it works, and this was just when it first came out. This was me with my phone videoing the screen, so it's not really high quality, but it's pretty cool, and you can watch the embryo develop. Down the bottom is hours, so this embryo is obviously going to be biopsied on day 6 to test for a genetic problem, and so you eventually see the embryo start to hatch out of its shell. Ordinarily, we're putting back an embryo which is day 5, so you don't see the final hatching bit. So that splits into 2 cells, 4 cells, and around about now would be about day 3, which is when we used to put embryos back. But what you'll see is an outer cell mass, which is a rim of cells around the outside with an inner cell mass developed right there, and so that's a blastocyst right there, and then you'll see it hatch out of it.
So the Jerry has visual, like you can see.
Yeah, that's video from, and we do now have an app, a Grow app, which doesn't give video like that, but gives each embryo which is in the Jerry gives a snapshot of each one every day. Wow. Obviously, it doesn't help pregnancy rates, but it probably just connects people to the process a little bit. Yeah, because having an egg pick up and then not knowing, you hear it but across the phone, but then not have any real interaction with anything until day 5 when you see your embryo up on the screen.
So the couples can watch that, can they?
Not the video, just snapshot, just photos. Oh, right. Yeah, on their phone. Yeah. Oh, wow. Then the aim of the game obviously is to try and replicate nature, and that is put the blastocyst on day 5 back in the uterus, which is when it would normally then be there. And the embryo transfer is done also in a different room, which we'll show you and explain to you the process of that as well. And we discussed all of that. That's just formation of a day 5 blastocyst. The inner cells, I've mentioned to you outer cells that we saw, that develops into the placenta, and the inner cell mass develops into the baby. And then 8 days after an embryo transfer, we do a pregnancy test and hopefully we have a good result. And of course, yeah.
You talked about a time where someone's put on a pill.
Yep.
Before the injection. What time difference are we talking between going on the pill and then starting the injection?
So it's usually about 2 weeks, pill to Cineral.
Yeah, 2 and a bit, yeah. About 3. And then all from the start of the pill to pregnancy test is 6 weeks.
So it is a long process. Certainly it's attractive to have a short cycle where, you know, the pill and the nasal spray is not involved and it's just period, if periods are coming regularly, and starting FSH injections on day 2 and then starting another injection to stop the brain pumping out any hormones. But the success rate's lower, so we stick with what is best. Historically, IVF labs have not published their success rates, and there's a push at least throughout Australia for each individual clinic to tell us what their success rates are, and the majority of clinics will not do that. Up until around about 5 years ago, it was actually published in a table, that is, each de-identified clinic was written down and their positive pregnancy test rates and their live birth rates were actually published, but you didn't know which clinic was which. We still submit our data on a yearly basis to a governing body, and it's not freely available clinic by clinic, which we have decided that we won't do, and we've decided for good or for bad that we'll be very open with our success rates. The downside is that, yes, it is determined partly by the way we present them, but what I like to present is positive pregnancy test rate, which of course is important, with the knowledge that that doesn't equate to live birth rate, because there are still women that have miscarriages, yeah? And there is always the question, does this whole process of IVF increase the chance of miscarriage? And I don't think that the answer is yes. I think that if miscarriage was going to happen, it's independent of whether it's via natural conception or an IVF cycle. The reason is probably a perception of an increased miscarriage rate is that we test the beta-HCG quite early, so we're testing it on day 8, and we can sometimes see a very low level, and we would call that a biochemical pregnancy, which in the normal world, no one would ever know really that that had occurred, and even if they weed on a stick, may not come up as a positive pregnancy test. But the answer to is there increased miscarriage because of IVF, and I think that the answer to that's no. So this is our data looking at positive pregnancy test rate. And the top bit is fresh embryo transfer, which is the bit that's applicable to most couples because the majority of couples don't get frozen embryos. So this was a couple of years ago, and the reason it's delayed a little bit is because we still need to submit our live birth data, and that lags obviously by 9 months. So in this calendar year, the positive pregnancy test rate for women that were less than age 38 was 59.8%, and for women in the older age category was 35.2%. And we're very happy with that, but we still understand people looking at that saying, you know, it'd be nice if it was 100%, and of course it would, but that's the numbers. So
what's the biggest age, or what's the maximum age you would recommend for IVF?
Look, I'm not sure that that's like a black and white answer, but it is more a practical answer, and that is that couples that come and sit in my office at age 42 to 43, we have more detailed data from our clinic than the numbers that I just gave you, And the facts are, for a 42-year-old to come through an IVF cycle, the chance of having a positive pregnancy test is 2 to 3%. And not that there is a limit, because there are some people that say, yes, in actual fact, even for closure down the track, I need to go through a cycle of IVF. But from a practical point of view, I just give couples, for good or for bad, the data that we have, and it becomes plainly apparent to them when it is the right time to proceed down the path of IVF and when it's not. So once we do a pregnancy test and we see that it is positive, we then look at clinical pregnancy, which is at 8 weeks in my rooms when we do a scan, or here at the clinic when we do a scan, do we see a heartbeat or not? And so we'll go back a step. I didn't actually talk about frozen. So frozen embryo transfer, at least in this year at our clinic, the frozen embryo transfer rate for women in the older age group was 44.2, which was lower than the fresh. But for some strange reason, the frozen embryo positive pregnancy test rate in this year was higher with the frozens than it was the fresh. That probably represents the fact that if you're in the older age group and the quality is so good that you get a frozen embryo, then there is quite a high chance that you'll probably fall pregnant with the frozen embryo transfer. Whereas all of the fresh numbers up the top include women who the embryology is poor and who are never going to get a frozen embryo transfer in the first place. Does that make sense? So our clinical data there is, do we see a heartbeat? And for the fresh, the blue is the younger age group, that nearly 60% dropped to 52%, accounting for miscarriage. And the red, fresh area, what was 35%, dropped to less than 30% after accounting for miscarriage. In my rooms, I actually don't talk that much about cost, but it's obviously important to people, and they want to know what the out-of-pocket expense for an IVF cycle after the Medicare rebate is. And to my surprise, I actually put this slide up thinking that people would be quite disappointed, but the majority of people have in their head that it's going to cost $10,000 for an IVF cycle. But that's the $10,000 is before Medicare eligibility, and the out-of-pocket expense is less than half of that. So when I put this slide in, think it'd be bad. It's actually probably good. And I spoke about testing embryos, which adds quite a large expense to the whole process. But for couples who are going down that path, creating the baby that is not affected by a significant medical condition is important to them. Cool. Dependent on where people are up to, the process of getting a fertility appointment. So myself, so I work at Newcastle Private. I have rooms there. The reason that I'm a little separate to the other two fertility specialists is that I do obstetrics as well. So I deliver babies and I need to be close to delivery suite. And so I've got rooms at Newcastle Private. The other two fertility specialists, Dr. McElveen and Dr. Fuller, have rooms at the Junction. We are the 3 fertility specialists here. The process of getting an appointment with any of us is that we need a GP referral, and that referral needs to go to the rooms and then just a phone call to any of our receptionists. The wait time, I think for all of us, is probably about 3 or 4 weeks. At least in my rooms, I do what I mentioned before, and that is try and cut out one appointment and send out a hormonal profile, which includes an AMH and a few other things, a pelvic ultrasound and a sperm analysis request, at least so that when we sit down, that we've got something to work off rather than me just saying, go away and have a hormonal profile and